Hello everyone and welcome to the case 29 of this case discussion series, and today we'll be discussing a very interesting neuroradiology case. So here we have a 40-year-old female who came with complaints of weakness and headache since the past 4 months now, and this is the MRI brain done for this patient. These are the T1 weighted images, axial section. We can see some encephalomalacia in the right cerebral peduncle of the midbrain, and also there is loss of flow void in the supraclinoid portion of the left ICA that is seen. These are the T2 weighted images. Again we can see that there are some ischemic changes in the right temporal region. That encephalomyelitic area is seen. These are the angiography images. We have to just trace the left ICA. The supraclinoid portion is, there is no signal that is seen. Left MCA and ACA also, there is some collateral vessels, thalamoperforate and lenticular striate branches that are seen. Left ACA and MCA are also not seen. So this is the report that I had given, that there was a small area of CSF signal on the sequences seen in the right cerebral peduncle of the midbrain, suggesting encephalomalacia resulting from chronic lacunar infarct. And also there was some chronic ischemic changes seen in the right temporal region. There was loss of signal with no as such filling defect seen in the left supraclinoid ICA, left MCA, ACA, and the left ACA was getting its supply from the anterior communicating artery. There were few tortuous lenticular striate and thalamoperforating arteries which was seen on the left side. So these features were suggestive of unilateral Moyamoya disease. So what exactly is Moyamoya disease? Is an idiopathic, non-inflammatory, non-atherosclerotic, progressive vaso-occlusive disease involving the terminal supraclinoid, ICAs and the circle of Willis. So it usually involves the bilateral internal carotid arteries, but in this case it was unilateral involvement, which is rare, and it is an idiopathic process. Since this female didn't have any history of atherosclerosis or any connective tissue disorder, it comes into Moyamoya disease. If there was some mimic, then it has to be labeled as Moyamoya syndrome. Moyamoya disease has a bimodal distribution. The first peak is in the early childhood at around 4 years of age, and the second peak is at 30 to 40 years of age, in which this female was falling in. Basic imaging finding of Moyamoya disease is based on the collateral circulation from a number of sources, including some abnormal Moyamoya vessels from the lenticular striate and thalamoperforating and the leptomeningeal branches, which was seen in our case. Some pial collaterals, which from the left less affected vessels like PCA, giving an IV sign, which is serpentine sulcal flare hyperintensity due to slow flow. Multiple foci of microbleeds and also prominent deep medullary veins giving a brush sign on susceptibility sequences can also be seen. The staging system for Moyamoya disease is Suzuki's system of staging, and it typically is given in conventional angiography. It's not yet applied for MR angiography.